So my name is John McCullagh. I'm a gay man living and aging with HIV, and I'm a social worker professionally, and I have worked with gay men and LGBT youth for over 30 years. And I was one of the founders of the Toronto Counselling Centre for Lesbians and Gays, which is now known as David Kelly's Services. And I was a counsellor there throughout the 80s, in the early years of the AIDS epidemic. I'm now retired, but I'm still volunteering in the HIV sector, so I'm kind of doing now for free what I used to do to get paid for.
So our agenda for tonight is to talk a little bit about the lived experiences of older adults with HIV or who are vulnerable to HIV. We're going to look at two case studies. One is a woman who is at risk of HIV, and we're going to watch a short video and have a discussion about that. The second one is a gentleman who's living with HIV and aging, and he's looking to seek some aging-related services. And again, we'll have a discussion about that. And then we'll do a summary in each case about the programs and services that are going on here in Toronto, but also across Canada, that address some of the issues that come up in those case studies. So we're hoping to use the case studies as a jumping off point to tell you about some of the things that are going on. HIV and aging is an emerging issue, something that a lot of people are paying attention to. And so we want to highlight some of the work that's going on. Also to reassure you that as you're aging with HIV, there are programs and services being considered and being put in place to help address some of the things that you might be facing. So we're going to draw a little bit at the beginning on the voices of people who contributed to the ACT Casey House long-term survivorship study. So you won't see the quotes necessarily up on the screen, but we drew on that material as kind of a background for some of the issues that people are facing as they age. And I look forward to debuting our case studies, which were filmed. Quigger and the OHTN collaborated to make these case studies, and we have 3 of the 4 actors in the room tonight, so you'll get to see that. Okay. So first I'm just going to tell you a little bit, just to set the stage, about a few trends in HIV and aging here in Canada. And then John is going to take you through talking about an exploration of the unique issues facing different groups of older adults who are affected by HIV. So first I'm going to talk about incidence. Now, does everyone know what incidence is? It's basically the number of new cases of an illness or a condition. So when we're talking about incidence, we mean new HIV diagnoses. And this table that you see in front of you shows that the number or the percent of all the HIV diagnoses that are among those who are 50 and older has actually increased over the past few years. So to give you some concrete numbers, in 1999, about 10% of people who were newly diagnosed with HIV were over 50. So that's about 1 in every 10 people. As of last year, it was about 18%, little more than 18%. So that's almost 1 in every 5 people who's newly diagnosed is over the age of 50. So that is important when we think about HIV prevention in older adults, is that increasingly that group is being exposed and is becoming HIV positive. So we need to think about that. And there's several reasons why older people are at risk of HIV infection. There's a lot of misconceptions because older people often didn't have any HIV or sexual health education during their younger years. And aren't the major targets of HIV prevention information that we see today. Usually that is geared towards younger people. We have increasing divorce rates, and so as people re-enter the dating scene at an older age and haven't had to negotiate safer sex before, they're now in a position where that might be something they don't really know how to bring up or how to discuss. We have access to drugs that enhance sexual function, so that makes sex a lot more possible for older people. And finally, physicians and other service providers, and frankly society as a whole, tends to have a perception that older people are asexual. Older people don't have sex, you know, we just don't think about it, and so doctors don't ask about sexual health risks. People don't bring them up because they don't want to be stigmatized as being like a dirty old man or, you know, whatever other stereotypes there are. And so that's problematic. And so we see this increase in new diagnoses amongst older people. Then when we look at prevalence is the total number of people living with any kind of illness or condition. So in this case, we're talking about HIV. And the cohort, the group of people living with HIV in Canada, is aging. And that's because people are living longer due to medical treatments being much improved from the early years. And so there are more and more and more people living with HIV in Canada because fewer people are passing away. But those people are also growing older. And so according to the UN, you can see in this graph here, in Western and Central Europe and North America, the estimate is that over 30% of people living with HIV are over the age of 50. And that's only increasing. And so there's a statistic out of the United States that they estimate that by 2017, 50% of their HIV positive population will be over the age of 50. Unfortunately, we don't have quite that good of statistics here in Canada. The Public Health Agency of Canada doesn't release prevalence data by age. And so that's something that we're in the process of negotiating with them to try to get a sense of what we might be able to expect from our own cohort of people living with HIV. So I'm going to turn it over to John, who is now going to talk to you about the 4 groups of older adults who are affected by HIV.
So we've got these 4 groups of people living with HIV, the people who have been living with HIV for a long time. People sometimes refer to that group as long-term survivors. People who've actually been living with HIV for a long time, but were only diagnosed in later life. And people who were diagnosed with HIV also in later life, but over the age of 50. And then older people who are vulnerable to HIV infection. And so before we look more specifically at those groups, I just want to talk a little bit about the difference between long-term survivorship and aging with HIV. Now, long-term survivors is a term that I think many of us are familiar with, and we often associate it with people who were diagnosed prior to the era of combination antiretroviral therapy in the mid-90s. But in fact, that is a term that even people in that group don't always necessarily relate to. One person in the ACT study that Kate referred to said, I personally don't use the term long-term survivor when talking about myself. Usually I just say I'm living with HIV or something like that in a positive context. But I'll use the term sometimes in conversation as a long-term survivor because I find it an easier reference point so people I'm talking to know my experience. But, you know, when we think of a long-term survivor, what about a child who's 15 who was born with HIV and has lived with HIV for 15 years, all their life? Is that person a long-term survivor? What about somebody who was who's 30 and was diagnosed when they were 20 and have lived for 1/3 of their life with HIV? What about people from newcomers to Canada who come from countries where HIV is endemic and yet there isn't therapy available to them? Are they long-term survivors? So there's really no definition of a long-term survivor, but however you define it, it's different from aging with HIV. When we talk of HIV, people in the business, researchers and policymakers and government and service providers, we talk about 50 as being old when you're living with HIV. And the reason for this, I think, is because it kind of the concept arose that most people were diagnosed younger, and they live beyond clinical expectations with the arrival of combination therapy. But that term 50 doesn't resonate with most Canadians. I mean, we think of 65 as being the age when we can maybe stop working. We used to have to stop working at 65. It's a time when many of us get our old age security and our Canada pension, but then you can get that at 62 or at 70. You can get a free a seniors movie ticket at 60. You can get on a Greyhound bus at 55. So, you know, we have different definitions of what is old. But in terms of people living with HIV, we use the term 50 because often people living with HIV for a long time, and particularly those who were diagnosed prior to the mid-90s, have less robust immune systems and have experienced perhaps medications that were more toxic than the ones we have today, and that has an impact on their body, and so we tend to look at 50 as the age of aging when you have living with HIV. So that's the term we're going to use tonight. So I'm going to introduce you to 4 people. First, I'd like you to meet Mark. So Mark says, I was diagnosed with HIV over 25 years ago. I've lost many friends to HIV during these decades. It's draining, but I've coped. I have good friends now. I didn't think I would live so long. I'm 62, and I'm wondering what's next. Well, as we talk about these 4 individuals I'm introducing to you, I'm going to show you this chart, but I'm not going to actually, you can read it, so I'm not going to actually go through each piece. But on the left, you've got what are the assets that these people bring to their particular situation, and what are the challenges they face. Well, Mark, who's an older adult who's lived with HIV for many, many years, he is a resilient above all. He's survived. He's a survivor. And he probably has a great history of grief and loss. Most of the people he grew up with perhaps now died. And I should also say that for many of us in the gay community in particular, even if we're not living with HIV, we too have lost those people. There aren't many people of my age, whether we're HIV positive or not, in the gay community in Toronto, because sadly many have passed on. But certainly for Mark, that's his situation, and that may impact his willingness to engage in a new relationship. Having lost so many people, you don't always want to put yourself make yourself vulnerable and maybe run the risk of losing somebody yet again. Because people like Mark were often told, you don't have long to live. Cash in your RSP if you have one. Just sell your savings. Just travel around the world because you're going to be dead in a couple of years. But guess what? Those people are still alive, and Mark is still alive, and so now he has no money. So he's financially insecure and is probably living on government benefits. One of the things he does have, though, is he has great knowledge about HIV. He has a great knowledge about the treatments that are available. He's very familiar with that. And he benefits from the newer medications that are available today, but he may also have side effects from the medications that he took that were more toxic. And some of those side effects, as we know, can be quite visible. And so Mark is somebody who can't really hide his HIV status necessarily, like many people diagnosed at a later age can, because of issues like about lipodystrophy and lipoatrophy. But he knows his way around the system, and he probably has a network of lots of positive friends, and he probably volunteers at an AIDS service organization as well as receives services from there. But he also might experience some accelerated aging, which we'll talk about in a moment, and he may have some age-related barriers to service because he's not yet 65, and so he can't see a gerontologist, even though he's having some issues that you would normally associate with people older than this guy at 62. And one of the things about people like Mark is that he looks at organizations like ACT and PWA not just as a place to get services to, but very much as a place that's a community, that's where he belongs, it's where he gets support. He may go there just for a lunch program to meet people he knows, to get a free haircut, to get a massage. And so I just want to kind of read you this quote here from somebody else in this ACT report that Kate mentioned earlier. What I was going to say with regard to support services, for me, it hasn't always just been what the agencies are designed to give you in the way of counselling or the food bank or the meals program or whatever you will. For me, over the years, what it has become is it has given structure to my week, and it has given me a reason to live and bring myself out of depression. I hadn't worked in a number of years, so when I came downtown, it was a chance to reacquaint myself with who I want to be and with who I am. And we put this Japanese quote here at the bottom. Ikigai is a Japanese word which means finding something meaningful to live for. Now I want you to meet Lionel. Lionel says, I only recently found out that I've had HIV. That I had HIV. All the years that I could have been taking medication if I would have just gone to get tested years ago. Now I have all these new medications to take in addition to my current meds, and I don't know how I'll manage it or if there's a point. After all, I've lived all this time without it. So Lionel is a guy who represents people who were infected with HIV years ago, but diagnosed later in older adulthood. And so this is a guy who's been HIV positive maybe for many years and hasn't known it. And I just want to make a point here, is that it's people in this group, whether they're over 50 or under 50, it's this group of people who prior to diagnosis and treatment, are largely responsible for the transmission of HIV, the virus, to other people. Because we know now that with the therapy we have, and if we have an undetectable viral load, we're very unlikely to pass on that infection. But this is a guy who's lived probably with a very high viral load for many years, and if he's been having sex and not knowing he was positive, he could have passed it on. His immune system is likely very compromised because the virus has been doing its damage for many years unknown to him. And sadly, people like Lionel often get an AIDS diagnosis at the same time that they learn they're HIV positive. And of course, that can have a big impact on his life expectancy. He's also probably more difficult to treat because he may have opportunistic infections and other infections and issues that he has either as a result of HIV or just because he's getting older and he has other complications. And so they need to treat HIV on top of everything else. And so he probably takes lots of drugs and lots of prescribed drugs. But the positive, he's learned to cope with many health issues in his life, perhaps, and perhaps living to 62, maybe some traumatic events. And even though he's been living with HIV for a long time because he didn't know it, he hasn't faced the stigma that many of us who know we're positive do. So Bridget says, I was diagnosed with HIV last year after getting into a new relationship. I've known this man and his late wife for 20 years. I didn't think I would get HIV. I'm probably the only 55-year-old to get HIV. I'm ashamed to look for support. I don't think I could ever tell my children. So Bridget is an example of someone who was infected and diagnosed with HIV after the age of 50. Now, what's good about that for her is that she's been in good health up to now. And she's probably been working and has other supports. So she's probably comfortably living somewhere nice, and she's probably has a job and financial resources. But the thing is that she totally lacks knowledge of HIV. She knows nothing about it, except probably what she remembers from the bad old days. And so she, all she knows is, oh, you get AIDS and you die. So she's extremely fearful of what it means to get this diagnosis in later life. And, of course, that lack of knowledge means she also doesn't know the supports and programs and services that are available to her. On the other hand, because she's a more mature person, she's very compliant with meds once she starts them. And, of course, that prevents any complications developing. And, of course, that also means she has better long-term health outcomes. She also benefits from the newer generation of medications that are easier to take and have few, if any, side effects. And just to, before I go on to the next one, I just want to give you a quote from a service provider here in Toronto, one of the AIDS service organizations, who's talking about the difference between people who were recently diagnosed and those who've been diagnosed a long time. This worker says, "I think with recently diagnosed people, they're almost invariably more hopeful, knowing that treatments are available, know that some of the long-term side effects may be avoided. They may have very minimal disruptions in their work. They're often employed people. So there's a vast difference between long-term survivors and more recently diagnosed people, I would say." And before I go on to my last guy I want to introduce you to, I just also want to talk a little bit about how the age group, the time when you actually diagnose, what stage of your life were, does impact significantly in how you respond to your diagnosis. So in the first column here, you've got the guy who was born in 1964, which means he's now age 50, and he was diagnosed in 1994 at the age of 30. And then you've got another guy in the middle column who was also diagnosed in 1994, but he was born in 1945, and so is 68 now. 68 now, and he was diagnosed at the age of almost 50. So there's a 20-year difference there. So the second guy, although he was diagnosed in the same year, has probably may well be well established in a job, in a career, in a relationship, whereas the younger guy is just starting out in life and has none of that. And then you've got the guy born in 1945, as the middle guy was. Actually, I don't think these people are 68. I think they're 69. But anyway, ignore that. Our math is right. Born December, okay. Right. So this guy in the last column was diagnosed in 2009. And so he was 63 when he was diagnosed. So he's even, 15 years or so older than the middle guy. So you see this, so where you were at the time of your diagnosis, it does impact how you handle the diagnosis. And I should just also say, it's different if you were diagnosed prior to the introduction of antiretroviral therapy, as the first two guys were. So the final guy I want to introduce you to is Paolo. So Paolo says, "I'm 64 now and stopped going to the bars and clubs quite some time ago. They're full of young guys and I feel out of place there. But a year ago, I heard about this bathhouse where older guys go. I like it there. I feel I fit in. Strange though, not a lot of guys use condoms there. So I stopped using them too. They kill my heart on. I know it's risky, but hey, if I get HIV with the meds they have today, it's not the end of the world." So Paolo is an older adult who's HIV negative, but vulnerable to HIV, obviously, because of his behavior. So the great thing he brings to this situation is that he's not infected. He's not yet infected. So he can benefit from HIV prevention efforts. The problem is, as Kate said earlier, prevention messages are not often focused on guys like Paolo. He's not seen as a risk either by physicians or service providers. And he may not perceive himself really to be at risk. If he's not gay, the people like him would say, well, only gay guys or drug users get HIV. And I recall our departing mayor said that at one point, not so long ago. So the result is that sexual health services are not geared to the needs of people like Paolo. Other challenges are, as if he's straight, particularly, he may have lacked sexual health information because of his age, and it just wasn't talked about when he was young. And if he's gay, as we've just seen, he may minimize getting HIV, because it's no longer, I'm not going to die of HIV, I'm going to die of something else. So, I mean, that's essentially what power is all about. So those are the four kind of people who are living with or vulnerable to HIV to focus our discussion today.
I'm going to highlight that these are questions that people ask themselves regardless of whether they're living with HIV or not. So the questions in the middle, in the green, are questions that most older adults might start to consider as they age. Questions about, you know, who am I? What am I doing with my life? Perhaps now that I'm not able to work or be as active in my community. Who am I going to spend my time with? How long will I be able to work if I am working? Will I have enough money to live after I stop working or after I stop collecting certain benefits and have to move to a different system? Where will I go? Will people there be prepared to meet my needs? These are questions that I think everyone asks themselves as they age. But then we add the outer circle, which is kind of the additional context of growing old with HIV. And so there are, in addition to those questions in the middle, and I specifically want to just refer to the ageism piece, somebody asking, you know, am I still relevant? I think that's a big question in a youth-oriented society where we see older adults depicted certain ways in the media. We talk about older adults with certain language. There's stereotypes associated with aging, and younger people are really viewed as the ones who are productive and contributing. And so that kind of puts a cloud around everything to do with aging, unfortunately, because I think older adulthood can be a very good time of life for many reasons. But that ageism piece kind of tends to cloud things. And then in addition, in that outer yellow circle, there's those aspects to do with aging with HIV. So there's stigma, for example, in addition to ageism. You might face stigma with regard to your HIV status, with regard to sexual orientation or your gender expression. And so there are worries, like someone mentioned, about going into long-term care or going in needing non-HIV related services and facing kind of that stigma from either service providers or maybe even other people who are accessing those services. The second piece, as John mentioned earlier, is around multiple losses. So going into older age, many people do lose loved ones. And so you know, that loss experience of losing a spouse, a partner, a friend, a family member is something that is common to older people, sadly. But having a history where you've lost many people from your social circle at a much younger age, when you haven't expected that, can certainly compound those losses, because it means that each additional loss is a little bit harder and more built on top of the previous ones, right? So that's something that we do have to take into consideration when we think about isolation and the mental health of older adults. The next piece is around the impact of episodic illness like HIV on employment. So perhaps, as John mentioned when he was talking about Mark, some people who are living with HIV may not have been able to work at all during their early adult years, or may have been able to work part-time or sporadically when their health was good. But that does impact then contributions to your Canada pension plan. And then it does impact your income when it comes time to claim the benefits that you're eligible for when you retire, right? Or when you move from ODSP or your younger adult benefits onto your older adult benefits. So that's an additional concern and something that actually a lot of older adults are worried about money, especially in the age that the time between now when we retire or when we stop working and the time when we die is actually quite a significant amount of time. And so that can be quite expensive over 30 years or 20 years. Just as an interesting note, the old age security that kicks in when you're 65, used to be designed, it was implemented at a time when the lifespan of Canadians was 67. So they only expected you to need to live on that for 2 years, and now you might live for 30 years. So poverty and money issues are not unique to HIV, but there might be some complicating factors because of that work history. Also, people aging with HIV are what I'm going to call a new aging population. So, you know, we all know that in the recent history, people didn't survive into old age nearly as much or at all as they do now. And so the aging sector, people who work in long-term care, people who work in home care, don't necessarily have any training on the unique needs of people who are aging with HIV, and may not be prepared to address some of those things as they come into the system. And so that's where someone like me, whose job it is to provide education to those folks, comes into play. Also, age and function are not always kind of matching when it comes to HIV and aging. And so you may be 55, but you may have some of the ailments that are generally encountered in older people. So, for example, being frail, which means, you know, walking a little bit slower, being fatigued, having a lower grip strength, like these are kind of medical type measurements, but I'm just trying to explain what frailty is. Being frail tends to happen earlier in people living with HIV. And so if you go to access aging-related services, as you would if you were at risk of having a fall, for example, you may actually find yourself being too young to be eligible for those services, which is a little bit problematic. It's something we need to work on. And finally, as someone brought up, desirability. So those impacts of the early medications, the issues around ageism, especially in the gay community, and being seen as a desirable person to date, all come into play, and maybe especially important or salient for people aging with HIV. So that brings us to the end of this section where we wanted to address some of the issues of HIV and aging. Now we get to move into kind of the more fun parts where we'll do some case studies and we'll talk about all the things that are actually in place to address the issues that we've talked about so far. Okay, so I'm going to introduce you to case study number 1, which is about older adults who are vulnerable to HIV. And this is going to specifically focus on conversations about sexual health and HIV risk. The situation here is that the person in the video, Charlotte, who happens to be played by someone in this room, which you will see, is at her doctor, at her family doctor, and she's having a conversation about her health and well-being as part of her annual periodic maintenance checkup.
Good morning, Charlotte. How are you doing today?
I'm good, thanks, Dr. Wrigley.
So I see it's been about a year since we last saw each other. Is that right?
That sounds about right to me.
Okay, great. Is there anything in particular you'd like to discuss? Anything that's bothering you?
Nothing in particular.
Okay. Have you noticed any change in your health recently? Any major changes in your life?
Well, I haven't been sleeping very well lately.
Tell me more about that. Do you have trouble falling asleep, or are you having trouble staying asleep? Are you worried about something or someone?
Well, you know, David and I split up for good earlier this year.
Oh, Charlotte, I'm sorry to hear that. You two have been together for some time.
Yes, we were married for 22 years. With the kids both moving out for school these last few years, we realized that we don't really have that much in common anymore. At first it was really devastating, actually, to realize that. Tanya and Mark were quite upset about it. I was really worried about them.
Are there friends or family members you feel comfortable confiding in?
Yeah, my best friend Sue has been a real rock for me. I couldn't have made it through without her.
And how are things now?
I still worry about the kids quite a bit, but I'm adjusting to being on my own. It's something I've really never done before.
Are you still working in telecommunications?
Yes, still manager of sales, same company, only 5 years to retirement.
And how about outside of your work? What do you do in your spare time?
I stay in touch with the kids, I read, I take a yoga class at the Y a couple times a week, I get out with Sue for a movie, glass of wine occasionally.
Okay, very good. How much do you drink in a week on average?
Oh, maybe 3 drinks, sometimes none. I usually only drink when I'm out for dinner or with friends.
And do you still smoke?
I do, unfortunately. This year just wasn't a good time for me to try to quit.
I understand, but I really encourage you to consider quitting as soon as you feel ready. I'm here to help. We've talked about that before.
Yes, I know. Thanks.
And how about your diet?
I eat pretty well, I think. I usually make most of my meals, saving money, which is a bit tight since the separation.
That's great. Don't forget about your fruits and veggies when you can. Your body mass index is good, so I'm not too worried about you there. Are you taking any supplements?
Just ginseng. Sue told me it helped with her hot flashes, so I thought I'd give it a try.
Okay, I'm not sure there's much evidence to suggest that will help, but since you're not on any other medications, I think it's fine to continue taking it if you feel like it's working for you. The nurse was in to take your blood pressure today, and that looks good.
Great.
I see here that your vaccinations are all up to date. Did you have a flu shot this year?
Yes.
That's good. You're due for a mammogram, so I'll make a referral for you. And it looks like you had a pap test and completed your fecal occult blood test for colon cancer last year, so no need to do it again this time. Since you have a family history of osteoporosis, I'm going to send you for a bone mineral density. Is that okay?
I'm not 80. Do you really think that's necessary?
Well, I think it might be a good idea to get a baseline now that you've reached menopause, just to be sure. I'll also order the standard blood work, so that just about covers it, unless you have any more questions.
I did have one other thing I wanted to talk about.
Okay, Charlotte, what's that?
Well, since the divorce, I've been kind of lonely.
Okay.
And it's not like I'm out picking up men all the time. I have been out on some dates recently. I feel really strange talking to you about this. Oh, never mind.
Oh, it's okay. You can talk to me about any aspect of your health. There's no need to be embarrassed.
Okay. It feels kind of strange to be dating again. David and I met in university. That was such a long time ago. I'm not used to these new ways of doing things.
Right. Are you thinking about becoming intimate with any of these new men you're dating?
Well, I guess I already was with one of them. It didn't lead to anything, but it was a fun distraction. Now I'm seeing someone new and really enjoying spending time with him.
And when you say you've been intimate, do you mean having intercourse?
Oh, yes. This is so embarrassing.
Well, there's no need to be embarrassed. I'm only asking because there are different concerns to discuss with different activities. And when you have sex, are you using condoms?
No. Both these guys were married for most of their lives, too. I don't think they're the type that sleep around or use drugs. And besides, I can't get pregnant anymore.
Even so, did you know you can get a sexually transmitted infection at any age?
But most people who get STDs are younger and sleeping around, aren't they? The really bad stuff like HIV usually only happens to gay men anyways. I've seen the posters in the subway.
Well, actually, among adults in your age group, similar proportions of new HIV cases occur among gay men and heterosexual couples. Sex is the biggest risk activity.
Seriously, I had no idea. Now I'm a bit scared. This isn't something I've ever had to deal with before.
It's nothing to be nervous about, Charlotte, just something to be aware of. Would you feel comfortable talking to your current partner about using a condom?
Isn't that going to seem a little strange, now that we've already had sex without a condom? He says he has problems keeping it up, so I don't think he'll be too keen.
Well, you might start the conversation by telling him that you came to see me today and learn something new. As a postmenopausal woman, it may be easier for you to become HIV positive.
Really? Why?
Well, when you go into menopause, your body starts producing less lubrication, and the lining in your vagina becomes thinner. You may have noticed more recently that using artificial lubricant makes sex more comfortable and enjoyable for you.
I had noticed that. I thought I was just nervous to be sleeping with a new man.
Well, you might be, but it's also a normal change among women as they age.
Huh. The things you learn. Lubricant is one thing, but I don't want him to think I'm a nervous old woman. He's handsome, he's outgoing, he could probably have his pick of the single women in his office, even a few who are much younger than me. If I start making rules about the way we have to do things, he might just up and go.
That sounds like a difficult situation to manage. It sounds like this relationship is important to you.
It is. I think we really do have a good connection.
Well, maybe that's something you can build on. If you care about each other, keeping each other healthy is a way to demonstrate that.
That's true.
If you agree to use condoms moving forward, and that is problematic for him, for example, he can't keep an erection, that's something his doctor can likely help with.
Okay. I'm not sure he'd like having asked someone for help with that.
I know. These conversations are difficult to have. We've managed today, though, right?
I guess so, but men are a little different.
That might be true, but if he has a good relationship with his doctor, the awkwardness will only last a minute or two. But back to your health for a minute, Charlotte. Have you ever had an STI test before or an HIV test?
No. Why would I? I've only slept with 3 people in my entire life, and 2 have been in the past year.
Yes, you're right that you aren't someone that doctors would consider high risk, but I still think it's worth ordering the test. It's important to detect HIV as soon as possible, in the rare event you test positive, as it means you can get treatment quickly. That's especially critical for older people.
Okay, if you think I should be tested, I guess I should be.
As I mentioned, Charlotte, I'm not too worried about your level of risk, but it's always better to be safe, right?
True. I wouldn't want to be sick and not know about it. My kids need me.
Exactly. So I'll add that to your lab requisition then. When the results come back in about 2 weeks, you can come back in for a chat. That way, you can let me know if you've been able to have a conversation with your partner and if there's anything more you need from me.
Okay. I'm still a little nervous about having that conversation.
Would it help to have someone else to bounce ideas off of? Yeah. There are a number of organizations in the city whose staff are expert on sexual health. Their services are 100% confidential, and they could be a great resource. Would it help to talk to someone like that?
Yeah, I think so.
There are also some online resources. I'm going to just write these down for you, like youshouldknow.ca and safersexforseniors.org.
Okay, thanks very much.
Yeah, no problem, Charlotte. Thanks for confiding in me today, and I'm glad we had this discussion. Are you okay to come back in a couple of weeks so we could follow up on this?
Yeah, that works for me.
That would be great. Thanks for coming in today.
Thanks.
Thank you.
All of these things came up through the course of Charlotte and Dr. Wrigley's discussion. So there was some individual health-related topics. There was the topics related to intimacy and sexual health. There were some social issues that came up. And there were, of course, the services that he was talking about with her around the end of the video. So a few things that I just wanted to highlight. For example, the biological changes associated with aging. So for women, he mentions that when you go into menopause, you actually become more susceptible to HIV infection. I don't think that that's something that a lot of women know. And I think that it was very responsible of her physician to actually take that opportunity to educate her around that. We heard about rejection. So we heard Charlotte say that she was worried about negotiating safer sex with her partner because he could technically date anyone he wanted, and she was worried about that. And I think that's a real concern for people. And I think that Dr. Wrigley in the video did try to address that with her, did try to talk about how she could broach the conversation with him, did offer some resources if she wanted some more support around planning for that conversation. But ultimately, her doctor can't guarantee her that that rejection is not going to happen. And so that's something that each individual has to kind of negotiate within themselves before they even go to their partner. And then finally, I hope you noticed that he did do some pre-test counseling with her around talking about her risk level, and he did invite her to come back when her test results came back. So there was that pre-post counseling built in. So I'm going to just talk briefly about some services that are available here in Canada that might have been helpful to Charlotte as she tried to navigate her journey and understand more her vulnerability to HIV. So the first one is offered by Positive Women's Network, which is located in BC, but most of their services in their health promotion program are actually offered online. And so perhaps having access to these online resources might have been helpful to Charlotte. They do have a website, and Dr. Wrigley does recommend this to her at the end of the video, called youshouldknow.ca. And this website is actually geared towards middle-aged women who might be wanting information on sexually transmitted infections, relationships, aging, sexual health, etc. So that might have been useful to her. And they also publish a variety of other pieces of information through social media and through reports that might have been helpful resources had she known about them. I want to draw your attention to what I think was the first aging-related World AIDS Day campaign that was done by the Canadian AIDS Society last year. The campaign was called It's Not Over. And basically the premise was that if you're over 50 and you think you're not at risk, think again. If you think people aging with HIV aren't faced with serious health issues, think again. And if you think the fight against HIV/AIDS is over, think again. And so this was geared towards older adults and the population as a whole. But this marketing campaign reached 500,000 people. And we created in partnership with CAS 6 HIV and aging related fact sheets, which you can find on the CAS website if you're interested in checking them out. And there were over 1,000, well, almost 1,500 page views where those fact sheets were located. So this is a way that information is gradually starting to reach out to older audiences. The next thing is actually a project near and dear to my heart because it is a Quigger project in collaboration with ACREA, which is the AIDS Community Research Initiative of America in New York City, and the Canadian Home Care Association. And what we did here was we provided training for service providers from the HIV sector and from the aging sector. And we brought them together into one room to talk about HIV and aging. Now you can imagine that they came into that room with very different levels of knowledge about HIV, about aging, and about HIV and aging. So it was part of the exercise was just trying to get everyone onto the same page. But what we really felt was important was to teach them how to talk to older adults about sex. So what we did was we talked about some statistics about the fact that most older adults are still involved in some kind of intimate activities, whether that's intercourse or other things. We talked about body changes and risk. We talked about prevention and testing and barriers to sexual health education. And we actually helped them have conversations and practice talking to older adults about sex. So this was a fun exercise, but it was also meant to point out that older adults are going to access services in all kinds of different places, through home care, through seniors organizations, through their doctors. And those folks need to be just as knowledgeable about HIV prevention as people in ASOs, because if you're an HIV negative older adult, the chance that you're going to end up in an ASO is very slim, to be honest. And so this information needs to be available elsewhere. There are many web resources. You heard a few of these mentioned by Dr. Wrigley in the video. There is actually a program at Centennial College in their continuing education division that offers workshops, the new Sex Ed 101, and pleasures and pitfalls of seniors dating. So if, you can actually go and take classes on these things, but you can also access these other resources online. And again, maybe these resources would have been helpful to someone like Charlotte who was needing information. This is another HIV prevention and testing campaign that was put together by the Hamilton AIDS Network, Men for Men, and Hamilton Public Health. And this testing campaign was targeted at older gay men who were over 40. And it was put together in response to there being a really high number of test results, positive test results in that region among that group of people. And so you can see that part of how they tried to appeal to an older crowd that may be aware of the risks of HIV but may not consider themselves personally susceptible was to use some of the campaigns you can see in the corner that have been used historically as HIV prevention campaigns. So maybe older men who had seen those along the way would actually recognize and appreciate that. And then finally...
So I'm just going to finally talk about Frank, which is a sexual health discussion group for gay and bi men held at ACT. It used to go under the term one night stand. It's now been this is the new name. It's I guess replicating an honest discussion. And what's interesting, I talked to Rui Perez just last week actually about this, because I said, is this really for older guys? Because we want to mention this tonight. And he said, actually, most of the people who go are older. I said, oh, that's interesting. And he said, yes, let me give you an example. We had a very popular workshop on online dating, to which everybody was over 50. Why, I said? He said, well, because young guys, they're on the internet all the time. They grew up with it. They know what online dating is all about. But older guys often have no idea. And when they put the pictures up online, which are very important, it's like a picture of their vacation trip to the Taj Mahal. And that doesn't quite go down too well. But it's also focused on helping guys who are older and trying to work out what sex means when you're of a certain age. And it's very affirming. So it avoids the stereotype that Kate mentioned earlier about when we're old, we're often considered to be dirty old men. Or as a friend of mine was told in a bar many years ago, an older guy was told, why don't you leave here? You're just taking up space. So those kind of horrible experiences that probably as gay guys we're aging, we probably have come across. This program really tries to overcome those stereotypes and help us to think positively about our sexuality, even though we're in later life. And the agenda is very much set by the participants. So there's an email list. There's Rui's email address there, or you can call and come out once a month. So this is the second interview with a new set of actors. It's about a gay man living with HIV, talking to a case manager at a home and community care organisation. Now, for those of you who may be wondering what a home and community care organisation is, these are organisations throughout the city here in the province that help older people and people with disability or chronic illness remain at home and prevent inappropriate or premature admission to residential care.
Hi, welcome to Heart at Home Care Solutions. I'm Sylvie. Must be Andrew.
I am, Sylvie. Thanks for seeing me.
No problem. Have a seat.
Thank you.
So, what could I do for you today?
Hi, Sylvie. Well, I'm a bit concerned about what supports are going to be available to me as I age with a chronic illness. And I think I might need a little help soon. And I just want to find out what my options are.
Okay, well, you've come to the right place. Let me start by telling you a bit about the services that we offer, and you can tell me what you think you might need. Does that sound okay?
Sure.
Okay. Well, in terms of home care, we provide nursing support, physiotherapy, occupational therapy, case management, social work, and personal support. And we also provide referrals to supportive housing and long-term care if you're thinking about residential options. What do you think you might need?
I'm not really sure at this point, Sylvie. I don't really know what to expect. As far as I can tell, no one does, not even my doctor. Most people I knew who were sick, they died before they got old.
Okay, well, I'm not sure I quite follow you. You seem young and well to me compared to the people I see normally. Do you mind my asking what type of chronic illness you're dealing with? That might help me identify some of the services that would be the best.
I'm living with HIV, and I have been so since 1990.
Okay, I see. Well, I don't think you have any reason to worry, honestly. Likely you're not going to need our services for a very long time. People live a long and healthy life with that these days, right? I mean, treatment, it's really effective. We used to care for so many people dying with HIV in the 80s, but we hardly see anyone anymore.
Yeah, the treatments are good, but I'm starting to notice some changes in my health, and I'm not sure if they're aging related. You know, I'm 55, I'm no spring chicken, or if they're from my HIV.
Okay, well, what kinds of changes?
Well, sometimes I forget to take my medication for one, and I've always been really good about it, and it's part of my routine after all these years, but I'm also finding it a bit difficult to concentrate.
Okay, well, I wouldn't be too concerned about those things just yet. They sound pretty minor.
Remembering to take my meds is pretty major, actually, Sylvie. And I heard that a lot of people aging with HIV have memory problems, and I'm starting to feel like maybe that's happening to me too.
Okay, well, do you live with anyone else? Have they noticed any changes?
I haven't asked my partner. I'm too embarrassed about it.
Okay, well, I know it can be troubling, but the first step might be to ask your wife if she's noticed anything.
My husband.
Right, sorry. Okay, I guess I made an assumption there. Your husband, yes. Okay, if your memory issues continue to interfere with your daily activities, we might be able to provide some support. An occupational therapist can help you devise strategies for medication adherence.
That's good to know. Honestly, I didn't really know what occupational therapists did. I probably couldn't afford it, though, Sylvie. Money's really tight for Jorge and I, and he works part-time shift work, and I'm on social assistance, and neither of us has medical insurance.
Okay, well, we would need to do a formal intake assessment, but if you do qualify for our home care program, then the OT services would actually be included.
That's great. My doctor never mentioned that. Jorge and I don't have too many friends. We lost so many to HIV in the 80s. And our place isn't exactly a palace, so we don't bring people over here anyways.
Okay, well, it sounds like maybe you'd be interested in meeting some new people or participating in some cheap or free activities.
I think it would be good for me to get out of the apartment, actually. But sometimes I just don't have the energy. You know, I do volunteer at a local animal shelter, but half the time I don't make it to my shift.
Okay, well, let me think. I know the local senior center offers a variety of daytime classes, field trips. It might be a good time of day for you. They're all free. Why don't you see about joining?
Well, I thought about that, but I'm not eligible. You have to be 65 to go there, and I'm 55, although sometimes I feel like I have the body of a 65-year-old. But unfortunately, that doesn't count.
Okay, right. I hadn't thought of that. You are right about the eligibility criteria. I'm pretty sure you have to be a senior now that I think about it. But what do you mean about feeling 65?
I don't know. I get tired fast. It takes me twice as long to do things as it used to. I just can't be bothered sometimes. You know, I don't know whether it's my heart disease, could be my HIV, could be my age, could be lots of things, really.
Okay, well, have you tried talking with other people who are aging with HIV? What kinds of things do they experience? What about joining a group at your local HIV organization?
You know, there's lots of young guys there, and they're always talking about hooking up and partying, and that's just not my thing. Also, I don't want to talk about my HIV. I live it every day and have for years, and I don't need to be reminded of it all the time.
Okay, well, that's fair enough. Maybe it would make a difference if you had someone to help around the house a bit?
Might, but I can't afford to hire someone. Besides, no one would take a job cleaning my tiny apartment when they can make triple the money at the big houses up the street.
Okay, well, did you know that home care services can include light housekeeping support from a personal support worker?
No, I didn't. So you're saying somebody can come and clean my house for free? Why didn't somebody tell me this sooner?
Okay, well, they won't do it for just anyone, but if you're having difficulty and Jorge is out at work a lot and having this support means you guys can continue to live together at home, then yeah, maybe that help is available.
So maybe things are not so bad in the short term, but what's going to happen to me if things get worse? You know, except for Jorge, I've got no family to take care of me. And I don't have money to pay for care, and that's only going to get worse when I get cut off my social assistance and transfer to old age security in a few more years. A guy like me who hasn't worked his whole life doesn't have a pension. No club bed either, I'm afraid.
Well, it does sound like you're feeling pretty overwhelmed, Andrew, am I right?
I feel like there's all these problems and I have nowhere to turn.
Besides Jorge, do you have anyone to talk to about all these worries? Have you asked your doctor about it?
No, he's usually in a hurry to get me in and out in 10 minutes. He says my numbers are good and I shouldn't worry. My treatment's working, and it is. So I try not to bother him about the small stuff like my foot pain or my worries. I just deal with that on my own.
Okay. Well, if there were someone you could talk to about your feelings, would you want to take that opportunity?
Yeah, I guess.
Okay, well, I can look into that for you.
Because, like, what's going to happen to me? What if I can't live at home anymore? Going into long-term care, you know, would be my worst nightmare.
A lot of people feel that way, actually. Luckily, very few people actually end up in long-term care.
Well, at least most people don't have to pretend to be someone they're not when they go into those places. I've seen how some people respond to folks like me. I was looking for a new dentist recently, and I had multiple office receptionists turn me away when I said I was positive. And people from my generation aren't exactly welcoming either. Imagine what my roommate would say when Jorge shows up and starts kissing me.
Okay, well, I do know the stories that circulate about long-term care are really awful, and it's a difficult and scary time for anyone, regardless of whether they're HIV positive or not. But if it does put you at ease a little bit, there are several long-term care facilities in the city that are LGBT friendly, and I do know at least one has had residents who are living with HIV, so their staff has received training and they know how to provide good care.
Oh, well, that makes me feel a bit better. I just don't think I can handle the stigma all over again. I've been there, done that many times. But just because I'm getting old doesn't mean to say that I don't want sex every now and again.
I totally understand, and we can certainly do some research before that would ever become an issue into a facility that could be welcoming and provide you with a private space to do that.
Well, thank you. That makes me feel a lot better. Thank you so much for talking to me about all these things.
Absolutely. It's my pleasure, and please do let me know when you're ready to book that formal assessment, and we'll talk again.
Thank you so much, Sophie.
Nice to meet you.
You too. Thank you. As Kate's chart showed, there were aspects of the clinical and medical piece that they talked about, the impact of the social determinants of health and the well-being of Andrew, his mental health challenges, and the various programs that he really needed. He really needs all those programs. So just to bring out just a few of them here for you, he talked about his fatigue, his tiredness. He couldn't go to, even going to his volunteer job at the animal shelter was a challenge. He was worried about his loss of ability to care for himself. He was worried about his heart disease. He was worried about memory loss. So these were kind of all things in this column that were a concern. In the second column, I think particularly his lack of financial resources, his lack of private insurance, the fact he's never worked, he's only got a government pension, he can't afford services. But he's very hopeful because he's suddenly told, yes, there's ways in which these services can be accessed. You just have to know where to look. And he's, I think, satisfied that the work in this organization, now that he has explained to her what living with HIV is all about, she's now able to come back and say, yes, okay, because she's actually a skilled professional. So now she has learned a bit herself, but she also can help this guy now look at some of the services. And the other thing I just would mention here is the focus on HIV. The doctor he goes to, which is an HIV doctor, wasn't addressing his need for occupational therapy. And he doesn't want to worry the doctor about his foot pain. So, I mean, that's, again, the interaction between a physician and a patient that isn't always very helpful. He's very anxious and very worried about what's going to happen to him, so that kind of uncertainty. And he lacks a lot of motivation. It leads to his isolation. So these are all the things we talked about earlier. So we'll leave it at that at the moment.
So now I have the pleasure of telling you about some programs and services that are going on again, both here in Toronto and across Canada, to address some of the needs that came up in the video. So the first thing I'm going to talk about is supportive housing. And generally, these supportive housing programs are for high needs, people who are living with HIV, who have complex comorbidities. So they're living not only with HIV, but also potentially with mental health issues, substance use, other physical comorbidities like diabetes, heart disease, COPD. Sometimes they're coming from having no place to live. But many of the people who are accessing these programs across Canada, and specifically as I've grown to know these programs specifically, are older adults. Large portions of their clients are people who are over 50 because they're experiencing specifically cognitive changes that are happening as they age. So an example right here in Toronto, which is a great piece that's just kind of emerging, is this HIV/AIDS complex care pilot project, which Fife House is the lead on, but it's actually a partnership between 7 different agencies. And they have 7 housing, what they call housing reintegration units. And specifically, these are for people living with HIV who have 2 or more comorbidities, whose housing is at risk, or they're using extreme amounts of healthcare services. So whether that's home care services or whether they're making frequent trips to emergency or being admitted to hospital on a regular basis and are clearly not coping on their own, living independently, and need some pretty serious support in order to be able to not go into long-term care. And so there's also 20 community dwelling clients who might require some wraparound services. So you can either live in a unit that's provided by Fife House and the other agencies, or you can live in your own home. But this program provides these wraparound services, everything from case management, personal support workers, nurses, rehabilitation specialists, people who call with reminders about taking medications, things like that. And this program is emerging. It's just finished its first year as a pilot, and they're planning on expanding it. And I think that it's services like this that will help people to be able to avoid those negative long-term care experiences and will be able to stay in community for longer, provided they have the right kinds of support and provided the service providers understand the needs of people who are aging with HIV. So we see similar programs also existing in Newfoundland through the AIDS Committee of Newfoundland and Labrador, in Montreal through Cédalise, and in Vancouver through the Dr. Peter Center. So these supportive housing opportunities are really starting to open up. Next, we have cognitive health programming. So we mentioned in the beginning discussion that cognitive health was something that people were worried about. Memory issues with concentration, making decisions, things like that. And so several organizations have started to pull together programming which is meant to help people maintain or enhance their cognitive function. So the AIDS Committee of North Bay, for example, uses a computer program called Posit Science. It's the same one that Sean Rourke and colleagues are using at St. Michael's Hospital in their current study. And they're offering that computer-based programming to people who want to do some, as they call, brain training. There's also a joint program from the Alzheimer's Society of Toronto and Casey House, which some of you might have heard of. They have previously offered an HIV dementia support group for caregivers, but newly this fall, they're offering a group called Living Well with HIV and Memory Changes. And that's actually for people who are living with HIV, who are experiencing maybe some mild cognitive impairments and who want an opportunity to chat about that in a group setting. And as I mentioned, at St. Michael's Hospital, they are doing a study that involves people having access to neuropsychiatric assessments, and then they're testing the benefits of brain fitness.
So I just want to talk a bit now about a program that is run at ACT. As we mentioned during the early discussion about the challenges around financial security, and this is a program that really helps people living with HIV to look at what they can do to plan ahead, which is what the gentleman over there talked about earlier as well. So it's a 5-part psychoeducational workshop series for people living with HIV, and it consists basically of guest speakers and then a facilitated group discussion amongst the participants. There are 5 parts: financial planning for people living with HIV closer to retirement age, HIV and private insurance and life insurance, drug coverage in HIV, estate planning, that's taxation, executors and wills, and funeral planning. Yeah, we have to think about that too. You can go to one or to all. You don't have to go to all of them. And the next series actually is starting in mid-February, on February the 18th, runs on 5 Wednesdays from February the 18th to March the 18th. Andrew is the group programs coordinator at ACT, and he's responsible for that program. So I'm quite sure that if you want to learn more or register for it, just speak to Andrew after the workshop tonight. And then the other program that we run at ACT is the one that I'm involved in, which is Planning for the Long Term, which is also a psychoeducational workshop series that explores the strategies of aging well with HIV. And that too, we have guest speakers and a facilitated group discussion. And this is held annually, so we do this every year. It's 3 hours a week for 10 weeks in the spring and 10 weeks in the fall. And you can attend both series or just one series. But when you sign up to one of the spring or the fall series, we do expect you to attend all sessions in a series because some of the conversations become pretty intense and we need to develop trust amongst the participants. And if people keep coming out of the group, it doesn't facilitate that trust. So every spring we talk about, we provide strategies to help us take care of ourselves and enhance our physical health as we age with HIV. So some of the topics we talk about are the latest treatment, HIV treatment and medical research, nutrition, the comorbidities we talked about earlier. We talk about how to mitigate issues that negatively impact our daily living, which is known by the term rehabilitation, which is what Kate's agency spends a lot of time doing. Harm reduction with respect to drug use, and physical aspects of our sexual health. And then every fall, we would provide practical information and ideas to help you achieve emotional health and to maintain that during difficult times and to bounce back after difficulties and stress. And so some of the topics we talk about there are good communication with our healthcare providers and others in our lives, brain health, cognitive health, and strategies to enhance memory, managing HIV disclosure, developing healthy and maintaining healthy relationships, managing stress, anxiety, and depression, sex and dating, and how to be resilient when we're facing all the issues we face. And so I always like to say the experts in this room during this series are actually all the participants, because we all bring our own life experience to this. But we do have during the first hour an outside expert who is professionally working in the area that we're talking about. And we provide a lot of resources and a lot of handouts to participants. Again, Andrew is the guy who is responsible for organizing this. So I certainly, those of you who haven't taken it, if you'd like to do so, I do encourage you to speak to Andrew about it. And the next group, I think, is starting in the spring and early April.
As we move on, and John mentioned talking about emotional support for aging with HIV, there are a number of support groups that operate in different locations that are meant specifically for older adults. And so there's the Survive to Thrive program run by the AIDS Bereavement and Resiliency Project. There's a peer group at Miel, Quebec. There are discussion groups for people over 50 at HARS, which is in Kingston, and at the AIDS Committee of Ottawa. They have one specifically for women called the Golden Girls Social, and also a 50-plus group that's open to anyone. Okay, so some print resources that are available to support people aging with HIV include the 1 Foot Forward JIPA Training Toolkit that was produced by the Canadian AIDS Society. And essentially, it's a self-guided module on how to be meaningfully engaged in your community. And so it covers a variety of topics, and that's accessible online. There's also an information piece on polypharmacy, which means taking multiple different medications. That was produced by Quigger and by CTAC, the Canadian Treatment Action Council. And the Positive Women's Network does create pocket guides specifically for women. So there's one on women living with HIV and one specifically on aging for women with HIV, as well as the HIV and aging brochure that many of you, I think, have probably seen from Katie. This is another program that aims to educate service providers. And so this one is specifically for service providers in long-term care facilities. It's a program that was put together by Casey House and the Rakai Centers. The Rakai Centers is a long-term care a pair of long-term care facilities here in Toronto. And their project is called Compassionate Care in a Changing Landscape. And what this is training videos for staff in long-term care that cover topics like bedside care, HIV, AIDS, and dementia, how to work with families and support networks. And there are 4 more videos to come. I think one is on substance use. I can't remember the topics for the other ones. But essentially, these videos are available free of charge to long-term care facilities across Canada. They're 20-minute videos, so these are perfect for training staff who work on a rotating schedule and who have busy work lives that don't let them go to an all-day training, for example. But it's a way to expose folks working in the sector to the needs of people living with HIV and how to provide care in a non-stigmatizing way. I'm just going to return to our project for a second. We talked about working together a little bit earlier when we were talking about prevention, but it also has an aspect on increasing knowledge and awareness to build capacity of service providers in community to deal with the issues that people aging with HIV are facing. So the modules that are included in that training for home and community care providers, for aging sector workers, are things like comorbidities, so dealing with multiple illnesses at the same time, polypharmacy, mental health, cognitive health, and substance use. And these are all specifically in the context of HIV and aging. So it's not just a general mental health workshop, but rather a workshop on mental health in the context of someone who's living with HIV and growing older. And we did arrange something called quick win projects that allowed service providers from the HIV sector and service providers from the aging sector to come together and work in partnerships to actually deliver new programs in their own agencies. And so sometimes that was training for staff, sometimes it was a new support group. There were a variety of initiatives that came out of that, but the idea is really to foster that concept of working together across sectors to help people deal with challenges.
But these are just some of the research issues around HIV and aging that are happening in Canada right now. We used some quotes from the first study from ACT and Casey House. That is, the link is there. The Heads Up study is a study that's looking at the challenges people with mild HIV-associated neurological disorder are experiencing. And there's the environmental scan of programs and services in Canada around HIV and aging, which is just looking at who's providing what, where in Canada, and where the gaps are, so that we can then know where we have to fill the gaps. And then this is a study from out of McMaster that's looking at people who have episodic disability, and the challenge there is that they are in and out of hospital, perhaps in and out of work, and that can be fairly predictable. And how are people coping with that over the long term? And then the last one is self-evidence. It's basically a scan of research activities that are being funded in Canada at the moment. So as you can see, lots of things are happening. Lots of programs are being developed in AIDS service organizations and other organizations. We're working across sectors to prepare healthcare providers to better serve people aging with HIV. There are lots of strategies in place to change policies at the government and agency level, and a lot of research is being done.